as Bruce said, my name is Ayan, and my family and I had arrived in New Zealand in 1994, fleeing Somalia when the civil war had broken out. And in that process, it took us 5 months to walk from the southern part of Somalia into Kenya, where in that process I had 3 older brothers, and in that journey 2 of my brothers had passed away. One had passed away from a snake bite, and the other had passed away from a waterborne disease. Along that way, in the first 2 weeks, my dad could no longer travel with us because they were killing all the men. So my mum with my 3 brothers and I just joined some other family members, not our immediate family members, but just people that we knew. And because it was a tribe-driven war, you had to sort of group yourself with your own kind, as they. And in that journey, we had come to Kenya, and in Kenya, we stayed there for 3 years. In those 3 years, my dad lived in another camp, maybe about 20 minutes away, and we didn't know till a month before we arrived in New Zealand. That's when we reunited. And fortunately, he was able to come with us, and my family settled in Mount Roskill, like most Somalis, in that time. And so my love for health sort of comes from my mum was a nurse, my grandfather was a doctor, and almost all on my mum's side, all her siblings are in the medical profession. But I could never deal with blood, vomit, and all the other stuff that comes with it. So public health was where I landed, and my first introduction to public health was through working with the FGM education program. So in 2007, my mum was going to do a research project with this FGM program. I had no idea what it was. And in that, I went to one of the ethics council meetings, and I was like, wow, this is actually quite a traumatic experience for young women, and decided from there I was going to form an education group for young women and go around educating young women around the issues around FGM, but also from that sort of discovered young Muslim women from refugee backgrounds weren't getting enough sexual health education from school because their parents would pull them out from sex ed classes. So there was young girls around the same age as me who never had any talks about puberty, periods, nothing, like absolutely nothing, and they were expected to get married and enter into these relationships without any actual understanding of their own bodily functions, but also what came with that, and from a culture that practices circumcision, what were the obstacles they were going to face. Okay, I'll actually stop telling stories and get into my presentation. So today I'm going to look at the definition of what a refugee is, how people get to New Zealand, look at FGM, the statistics around it, the definitions, the cultural context, because I think to understand FGM, you've got to understand it in its cultural form. It's a foreign concept to most Westerners, and it's barbaric and it's horrific, but when you're in a society where FGM is practiced and it's a normal thing, you have a different lens of looking at it. And then we'll finish off with a case study. I have put in front of you guys an evaluation. If you could please fill it out for me, that would be great. And also the case study as well. So UNHCR defines a person who is a refugee as a person who has a well-founded fear of prosecution for their race, religion, membership to a social group and things like that. And to be classed a refugee under UNHCR, you have to cross the border. Otherwise, you're just an internally displaced person. So globally, as of 2016, there was 65.6 million forcibly displaced people. Only 22.5 million of those were classified as refugees. 51% of those are under the age of 18, and only 1% of that population gets resettled into a host country. And on average, people wait up to 17 years to be resettled. So to become a refugee and settle in New Zealand, there's 3 ways in which this can happen. One is through our refugee quota, which will soon go up to 1,000. This is on an annual basis. On arrival, they are permanent residents. They get settled in Mangere for 6 weeks and get an introduction to education, the New Zealand health system and all the other stuff. And then they get support services from the Red Cross for up to 12 months, 6 to 12 months. And they're settled with a social housing home. The other category is the family support category. So that means someone who is a former refugee has to sponsor a family member over. They've got to pay for their flights and visas and everything like that. They don't get settled in Mangere, and so they pretty much get off the plane and are settled into the community. They have no real introduction to the New Zealand way of living. And with that comes a raft of issues, because the person who brings them over is responsible for them for up to 2 years. And as we know, not all the time does that really happen, that the person who sponsored them has put their life on hold to bring them over here, sometimes 5 to 6 to 8 years. And once they've arrived, they're safe, they're healthy, and then that family member can go on and live their life because they've almost have done their part. So there is a real gap in sort of enrolment to GP, catching up with immunisation, and a raft of other issues, including isolation and things like that happen. The other category is the asylum seeker category. And these 2 population groups are probably one of our most vulnerable refugee populations. For the asylum seeker population, they arrive in New Zealand, claim asylum, and they kind of have to look after themselves. They're not entitled to any support services. They kind of have to find their way around, and often will sometimes get taken advantage of, even people within their same ethnic group. So there's a lot of issues around that. So with our quota refugee group, we're seeing people from Afghanistan, Colombia, Sri Lanka, Syria, and Burma. And this will change depending on the geographical issues that are happening and the geopolitical climate that we're in. So there is phases to resettlement. So there's that initial phase where you have to flee. It's immediate, it's sudden. You don't really have documentation. You don't think about all the things you may need further down the track. You're only thinking about how are you going to be safe in that moment. For my family, my grandfather said to all his kids they had to leave in the morning. He said that, and he said by sunset you guys all have to go and figure it out. And so with people who've never travelled in cars, have never been outside of Somalia at that point, it's where do you go and how do you get there? So you just follow the masses. The second bit is getting to a host country. Once you've arrived in this host country, you kind of have to figure out their system of living. Are you loss of status, separation from family, fear of violence, because you don't know if the people you've escaped are also there, and how safe are you. There's a lot of issues around discrimination. As I showed you in the map before, a lot of the countries that end up hosting refugee population are developing nations themselves. So they're already resource poor settings. So it's around the anxiety of the future and things like that for the person who's in this new host country. And then the third bit around being resettled in a new country comes with its own challenges. So for some of our population, there's obviously a language barrier that occurs. There's the cultural differences. If you're used to a place where everyone looks like you, sounds like you, and has the same cultural norms, and you come to a completely different world. Like my parents had never seen a European person, in their lifetime. So even when we were in Kenya, it was very rare to see European faces. So when we came to New Zealand, it was completely a shock to the system. The climate, that's still a process of adjustment. Mental health issues is quite a big issue. When you're running away from danger, you don't think about what you're running from. It's just that fear-driven, it's getting yourself to safety. But after you've settled and that honeymoon phase of being safe and sound is over, is really dealing with the loss, the grieving, and everything else that you're missing. So there is quite a big, I think, component of mental health issues, although most of our communities will not talk about it because it's either you're well or you're crazy, or like you're having a psychotic episode. There's nothing in between. There's no depression, anxiety, stress. When I was doing my master's, and I would ring my grandmother and tell her I was stressed out, she's like, you've got a house, you've got food, and you can get to places. What's wrong with you? And I was like, well, you don't really understand. And thinking about it now is they truly don't understand. It's like you're either well or you're not, and anything else is seen as abnormal. So throughout my slides, the quotes that I've got are all from the 2008 and 1997 and 2008 health survey from the FGM education program. Can everyone see, or do I need to read it out? Okay, cool. As you're reading, all refugee people experience challenges through their migration process. The number and the nature of those experiences varies. Not all experience torture, but almost all will suffer some form of traumatic experience. For effective interaction and interventions, it's important to consider these processes that people have gone through in their migration journey. So why is it important to look at the needs of refugee populations? I think because they're quite vulnerable populations with low socioeconomic status once they've arrived, especially considering the families that come under family unification and the asylum-seeking population. They might not be entitled to different benefits and things like that. Coming to a new country comes with new health challenges for people. So when my mum first came and she started gaining weight, and our doctor was like, you need to start losing weight because you're heading towards getting diabetes. She was like, what do you mean I'm eating healthy? Because she was eating foods that she was cooking, not buying takeaway, and she thought because she was doing that, it meant that she was going to be healthy. But it was because the foods that we ate back home, you burnt it off because you walked everywhere. You did other forms of exercise. You had to walk 15 minutes to get your water, not 30 seconds to go to a tap. So all the other factors that contributed to keeping her weight down were no longer there. So it's really, the lifestyle stuff has an impact on the refugee populations, like cardiovascular disease, diabetes, poor oral health, especially for our Middle Eastern communities, because they eat the sweets and things like that, has an impact on it. Literacy levels and sort of health education in general. So a great factor in determining health-seeking behaviours is people's health experiences. So if you come from an African country, your health experiences are you go to a doctor when you're in dire need because you have to pay for it, it's privatised, you have to wait in line, there's no appointment system or anything like that. So you rock up when the doors open and you get your card that says you're the 100th person on the list for the day, and they might get to you, they might not get to you, and that process is repeated every day. So you might not actually ever see a doctor. So I think a good illustration is this picture, where this is a hospital in Somalia, and this is a maternity health hospital. This woman's had a C-section and has no anaesthetic or has no pain relief as well. So when a lot of Somali women were getting C-sections or any form of operation is considered dangerous, whether it's a minor tonsil, you're getting your tonsils removed, we see that as a minor operation, you're in and out in a day. Whereas any form of surgery in a developing country is life or death. And because it's a resource poor setting, people don't want to have surgery at any cost. The myths around healthcare as well, like people would rather see a traditional doctor or a traditional healer rather than going to get pills to solve their problems, especially around mental health. Like a lot of people would rather go to a spiritual healer, and a lot of our mental health myths are, your family's cursed for 7 generations. That's why if someone in your family has a mental health issue, it's that curse rather than it's a chemical imbalance. So there's low levels of health understanding, cultural norms and belief systems. The understanding of referral pathways is very limited. It's like, because in Africa, if you go to a specialist, if I pay the right amount, I can get it done in a day. Whereas in New Zealand, you're on a waiting list for up to 6 months. And people don't often just like, what's going on? Why is everything so slow? The lack of understanding around our health system is quite common. And for the last year, that's something that I've been working on, and is doing a 101 to the New Zealand public health system, whereas everything else that we're used to is so privatised. This was a woman who had died in the surgery because there was no blood transfusion. So this idea that simple things like blood transfusion and blood banks to us is very common, whereas in a lot of countries there's no such thing.